I'm Joseph Ischia and I'm speaking with Ada Cheung. She's an endocrinologist at the Austin Hospital and the APCR, as well as a researcher at the University of Melbourne. She gave an excellent talk today on the disease state, basically, of hypogonadism in men that have been treated for testicular cancer. So Ada, can you give us the highlights of your talk from today?
Yeah, sure. So we think that low testosterone levels after treatment for testicular cancer occurs in about 15% of individuals. And, one of the difficulties is actually ascertaining, whether a man actually has low testosterone levels. We do have some surveillance guidelines. So ANZUP have got some testing recommendations. They recommend testing 6 months after orchidectomy, and again at 2 years and 5 years. And similar recommendation exists in the UK. But testing is really important because the timing of measurement is critical.
Yes, and when should we test?
So testosterone has a circadian rhythm. It's higher in the morning, lower in the afternoon, and so you should always test first thing in the morning, early morning fasting levels.
Why fasting?
Because as soon as you eat, the testosterone levels drop.
Well, that's no good.
Testosterone's a very sensitive hormone. It will drop with eating. It will lower with any sort of illness. So getting it first thing in the morning in the fasting state is critical.
Okay, and we hear a lot about the symptoms of hypogonadism, but they're incredibly difficult to tease out, really.
They are. So the tricky thing is lower symptoms of hypogonadism or low testosterone is really non-specific. So many men get decreased sexual function, decreased libido, tiredness, fatigue, depression, and there are so many contributing factors when someone's been diagnosed with cancer that can lead to these symptoms. So working it out based on symptoms and signs is really tricky.
So when would you treat someone based on their symptoms or their testosterone level?
There is no hard evidence. So the evidence, it's low quality evidence, but my opinion is that I would generally treat someone if their total testosterone was less than 10 nanomoles per litre. I'd make sure that it was definitely a fasting early morning level and there wasn't any reversible cause like any acute illness or drugs affecting it. And if it was repeatedly less than 10, I would definitely consider treating. I might consider treating if it's less than 12 nanomoles per litre if in specific individualised circumstances. So if they were symptomatic, they had low libido, or if their LH, luteinizing hormone, was very high, which reflects primary hypogonadism, then I would also consider treating.
Okay. Well, testosterone, it sounds wonderful. Why don't we give it to everyone?
Why don't we give it? Exactly. It's actually been shown to be not the fountain of youth that people thought it was going to be. It affects fertility. So these are often young men in their 30s that get testicular cancer, and when you give testosterone, it's a contraceptive. It stops sperm production. So that's one reason not to. And we're also uncertain about the long-term side effects. So giving testosterone levels, getting high levels can be associated with increased hematocrit and polycythemia. And there's also some concern about potential cardiovascular risk. So you may have heard of the multi-centre T trials that have been a coordinated set of randomised controlled trials in older men in America, looking at various outcomes to try and answer some of the unanswered questions. And concerningly, after 12 months of treatment, the men on testosterone had increased coronary artery plaque. We don't know what that means, whether it translates to cardiovascular events, but it's a concern. And I think we should be conservative and only treat those who truly have low testosterone levels who are going to get a benefit.
Well, thank you, Ada. It's been an absolute pleasure having you here at ANZUP, and we look forward to seeing you more in the future.
It's a pleasure. Thank you for inviting me. Thanks, Joe.